But I'm going to just spin now into a little bit on therapy. Bimodal therapy of suppression of the RAAS system has been considered and tried in people, and there are a number of ways that you could do it. Obviously, most of them have involved an ACE inhibitor. Some have involved angiotensin II receptor blockers. Some have involved mineralocorticoid receptor blockers such as spironolactone and eplerenone, and potentially direct renin inhibitors could also be used here. No one has been very happy in human medicine and human cardiology with the combination of ACE inhibitors and ARBs because they got no obvious benefit, and the numbers of side effects, decrease in renal function and hypertension, were greater. So the ones that have had the most attention now are the combination of ACE inhibitors and spironolactone or eplerenone. So 3 trials. The RAAS trial I've already explained. This was the very first, and it used the first generation MRB. The second trial is the EPHESIS trial, and this compared total mortality in people that had an acute myocardial infarction and had developed heart failure. And people were then either given placebo or eplerenone. That's the second generation MRB, and it was developed because it has less side effects because it's a more specific binder to the aldosterone receptors. And what we see is that there was a statistically significant benefit in total mortality in these people post-MI, almost 3,000 patients. But what's really interesting to me is when you see how early these 2 curves break apart from each other. It's within 30 days, 60 days maybe. Very early. This shows you then that these drugs in combination, bimodal suppression of the RAAS is not only useful, but that the benefits occur very early in humans used as a model for dogs and cats. A group of European and American cardiologists got together and came up with what we call a consensus statement on the treatment and diagnosis of mitral valvular disease. This was published in 2009, and what I wanted to do was relate it to chronic treatment of heart failure and how this panel stood on the use of spironolactone. No consensus was reached regarding the use of spironolactone in dogs with early heart failure due to chronic valvular disease. We were using it not as a diuretic or advising it or speaking about it not as a diuretic, but as an aldosterone antagonist. It was used by some panelists prior to the onset of heart failure, once they had evidence of cardiac enlargement or remodeling. The majority of the panelists, however, did use it to treat congestive heart failure, and most often it was recommended for end-stage or refractory heart failure. The reason that I mention this is the consensus was released prior to publication of the prilactone study later on in that year. This is a survey of 100 ACEI boarded cardiologists, and it has to do with their opinion in their practice on the treatment of chronic heart failure. Not surprisingly, the number 1 drug was Lasix, furosemide. A very small percentage of people use something else. The second was an ACE inhibitor, didn't specify which one, and you can see that it was just about the same as furosemide. Third was pimobendan, and I think everyone agrees that triple therapy for heart failure in dogs with DCM and MR would involve those 3 drugs. And spironolactone, again, prior to publication of the SIVA study, less used, but one of the top 4 drugs used by these US cardiologists. This study is, everyone is familiar with it. This looked at 221 dogs with relatively mild heart failure, ISAC class 2, 92% of them. The rest were in 3 from 4 European studies. And the number of dogs who reached endpoint is rather small, but despite that, a significant benefit was seen in those dogs that received spironolactone plus standard therapy here in blue as compared to standard therapy plus placebo. So this was a placebo-controlled double-blind trial.